welcome you to the Day 2 fourth session of the School of Clinical Medicine and Research Bahamas Research Day, Session 4. We have a variety of keynote speakers and some other speakers, but at first I would like to do some housekeeping. I would like to acknowledge our sponsors, Cell Collab Clinical, the Consultants Physician Staff Association, Doctors Hospital, the Medical Association of the Bahamas, the Medical Protection Society, Nestle, the National Insurance Board, the Public Hospitals Authority, Spotterdoc, Springer Nature, STATA, the Ministry of Health and Wellness, and individuals such as Dr. Pinder Butler and Dr. Wells for their contribution. This session is accredited for 2.5 CME points, which can be claimed once you fill out the evaluation, and a QR code will be shared with you at the end of the session. Our first keynote speaker is Dr. Gloria Geraldo. She's a non-communicable disease expert and a mental health advisor for PAHO in Barbados. She's also a sub-regional program coordinator, and she joined PAHO in 2016, and much of her work is focused on cardiovascular disease prevention. And she also coordinates Hearts, an initiative with the Americas, which deals with chronic kidney disease. So without further ado, I will hand the floor over to Dr. Gloria Geraldo.
Thank you very much. Thank you very much for the invitation. And we would like to clarify, we do not have any conflicts of interest, and we also don't have any affiliations with any of the sponsors of the conference. We are delighted to have received an invitation from the organizers, but no any other affiliation. Thank you. So now I will pull up my slides, and I have enjoyed the afternoon session with very excellent presentations. And this afternoon, we are starting with a presentation that will take you a little bit away from clinical practice per se or exclusively to public health. So let me just make sure, may someone inform me which, if you're seeing the correct screen, not...
Yes, we are. We are at the beginning of your presentation.
Okay, and you see the correct one. Okay, very good. So I would like to take you from a journey of sharing a bit about data, how we obtain our data, where you can find our data from PAHO, WHO, and how we are taking this data on diabetes, on hypertension, on NCDs, and applying this data to transform it into action in the Americas, in the Bahamas, in the Caribbean. So let me start with, this is a publication that has been recently released by PAHO, and probably has been picked up by some media, which we're delighted that it happens, and it gets transmitted to the public, and in different types of journal articles or newspaper articles. So I'd like to start off by sharing this recent data, sharing where it comes from, because I think that just might have been at the inception or at the heart of our request for our presentation. So the NCDs at a glance is the latest publication. There is always a lag in time in terms of data. So this has an approximate 2 years lag. So it does contain the data for the pandemic, but it's still not up to today, October 23rd of 2025. So it has that's my disclaimer. So we know that we continue to see an increase in the deaths caused by NCDs. The data we had from, if we look at a period of 2 decades, 4 million deaths, and today, and to 2021, 6 million deaths. This is for the Americas, so for the whole continent of the Americas. And here we can see that breakdown in, you know, a bit more clearly. So from 9.2 million deaths to 6 million of those caused by NCDs. And this is, of course, no surprise to the audience, but we're just kind of setting the context. And of those 6 million, or the 65%, 2.3 is what we from WHO consider premature deaths, which is those deaths under the age of 70 years of age. And 6.6% diabetes, 6.7%, and other NCDs, which is in a whole cluster of many other conditions, are 30.4%. So this is all the overall picture. And as I mentioned, this is a snapshot of the latest data. And I'll, you know, go into a little bit into how we collect this data. Some of you may be familiar with it. But I brought as an example because it was also one of our asks, the PAHO Bahamas steps, or the Bahamas steps, I should say, utilizing the methodology. So the government of Bahamas, with the technical support of the Pan American Health Organization, conducted what is called the STEPS survey, population survey in 2019. I hope you are familiar with those results because this is such an important tool for the planning in terms of public health of the whole country. And some of the, in terms of the methodology, some of you, as I mentioned, may be familiar with this population-based survey. It utilizes 3 steps: face-to-face interviews, which include the life risk factors, the physical measures for blood pressure, weight, height, and the biochemical tests for blood and urine for glucose and cholesterol. And some of the major strengths is that it's a nationally representative survey. And of course, that we hope all the ministries and the governments in our region that conduct the survey utilize the results for planning. And this is what brought us here today, because some of the results that you probably not only see in your own clinical practice, but this is what the survey told us about the population of the Bahamas: a combined prevalence of overweight and obesity among adults of approximately 72%. Obesity, that's the combined overweight and obesity. Obesity alone, almost 44% of adults. And of course, we notice a higher prevalence of females. We do notice this in several countries. And that the adult prevalence of overweight and obesity in the Bahamas exceeds the regional average of the Americas. So we want to now take this information and put it into the context of the Americas entirely, as well as the global context. We also have some data on diabetes, which was close to 12% in the population. Again, this is now 2019. So this is, of course, probably has changed, but is the latest data we had from the STEP survey from Bahamas. Pre-diabetes around 7%. Now in this presentation, we're zooming in and zooming out. We're going back now to look at the whole entirety of the Americas, and you can take a few seconds to locate Bahamas here. This is the mortality rates per 100,000 population due to one of those 4 major NCDs. So we can see that Bahamas has, unfortunately, occupies one of the 10 top spots around the high mortality rate per NCDs. It is not in the first in the reddest lines, which is good, but it follows right after. So there is still, a lot of work that we need to do, and this is, where public health, working with ministries of health is our approach. I will go through a few more data slides, and then I will get into the action component and what is it that we are proposing to our ministries of health in the Bahamas and in the region for action in order to counteract this very dire epidemiological profile. So another measure that we utilize is as a premature mortality, and the in the Americas, the probability of dying between the ages of 30 and 70 years of age from many of the 4 major NCDs, you can see here for both sexes is currently 14%. And for males, it's a bit higher, 16.5%, and for females, slightly lower, 11.7%. There was a slight reduction, but it's not enough of a reduction for the global target that our governments around the world have committed to working towards this, to lowering this indicator, this probability of dying between 30 to 70 from any major NCD. Now let's look at how the Caribbean, the English-speaking Caribbean compares. So you may see on the right-hand side that when compared to the overall region of the Americas, unfortunately, the region of the English-speaking Caribbean fares slightly worse in terms of that probability, where it's 21.9% for males and 17.9% for females. So it is higher than for the region of the Americas. And then we have on our left the breakdown for the countries of the Americas and that of the English-speaking Caribbean. And we can see here Bahamas, where that person between the ages of 30 and 70 has a probability of 20% of dying from that, from an NCD prematurely. So again, please know that I am certain many of you may be familiar with this data because the majority of you may be working day in, day out, working with your patients precisely on these conditions. We're looking now from this public health perspective where we, as you have known, in the last few decades, the leading causes of death have not changed much. They continue the same three highest causes of death are the same in the last 2 decades. And we have a slight change just because I was mentioning earlier that this data now contains the COVID-19 data. And so there was just a slight movement among the 3 top causes of death, but all of our biostatisticians and epidemiologists to generate action through the programs that we are recommending. But this is a very important slide in terms of the cascade, and the red simply tells us that all over the Americas, we have great room of improvement to in terms of improving the rate of people diagnosed with hypertension. So we want to make our charts greener. The green represents those that are aware, that are treated, and are in control. So this is where we would like to move. And we can see here for females and males that Bahamas is approximately on the 4th place with achieving among the women, achieving relatively positive results in terms of those that are treated and in control, that is the green. But in the red, in the males, we see great opportunities for improvement. And as you can see, this is throughout the Americas. So we wanted to place into context what the data for Bahamas is and how does it look in context with the rest of the Americas. This is a closer look, less busy. Now here we've extracted the countries from the Caribbean. And this is what I was just mentioning, but you can see it more clearly where we stand in terms of how does Bahamas compare with its peer countries around, in the same geographical area in regards to hypertension among adults and how that hypertension cascade looks like. We'll do a little bit more of data now in terms of diabetes. We think it's important. We want to focus on diabetes, but giving, the whole multimorbidity that we encounter, it's important to be looking closely at both conditions. We also see, of course, that diabetes has been increasing throughout the world, but very especially in low and middle income countries like our countries in the Americas. We see that, as I just mentioned, in the Americas, same type of trend is observed in regards to the prevalence of diabetes, much reflecting what we observed in Bahamas as well. And in terms of comparing prevalence and treatment, so on the left hand, we have a chart for prevalence in the English-speaking Caribbean. And the right-hand side, we have treatment coverage for diabetes. So do we see there is a diversity in terms of treatment coverage? And it's also compared to the region of the Americas in both areas. So we see that Bahamas is doing fairly okay. There's always room for improvement, but its coverage, it's among kind of in the close to 50% in terms of coverage of diabetes treatment. The prevalence of obesity, this is highly concerning for globally, but also, of course, for the English-speaking Caribbean. And here is the visual of what we had mentioned earlier in terms of the prevalence of obesity. I will move a little faster through here. We did want to emphasize that, of course, the issue of obesity and overweight and obesity is a major risk as well for diabetes. Therefore, we're not doing well, and not only we're not doing well globally, we're not doing well in the region of the Americas. You can observe the upward trends for young children from 5 to 9 years old, from 10 to 19 years old, is exactly following the very same upward trends. So again, this is very highly likely the type of patients you're encountering in your practices. These are more detailed tables with a bit of projection. In the left-hand side, we see data for Bahamas with projections for 2030, where if the trajectories are maintained, we could be reaching up to the upwards of 80% in terms of combined overweight and obesity. Therefore, being a very important risk factor as well for the other conditions, for all the cardiovascular diseases, as well as diabetes. All this data can be found again in our data port for NCDs. So let's jump a little bit into action now. So with all this data that comes from the population-based surveys and other sources, we have resolutions that come from the World Health Assembly that the countries, the representatives of all the countries agreed to. So global NCD targets to halt the rise in diabetes. We also have resolutions about the coverage rates and the universal healthcare coverage. Therefore, we need to operationalize all these goals that are representatives from ministries of health around the world, including the Caribbean, including the Bahamas, have signed on to. So this is a bit more data, but as I imagine, this is what might be reflected in your own practice. This is, again, what we were mentioning, very close to the data from Bahamas. This is the regional diabetes prevalence of the most current data that we have, 13.3% for males, 12.9% for females. And this is another way of showing that in the red is the treatment gap for diabetes among all the countries in the Americas. So we have a very a very red chart here. And some of our the countries you connect, these are the short acronyms for the countries, but we need to work in how do we close that treatment gap. And this is a summary of what I've been showing, so I won't go through this. These are some of the data here more in a narrative form. But let me move on to what is it and what is the action that we are taking from PAHO. So we've launched an initiative called the Better Care for NCDs, which is to accelerate actions in primary healthcare. The purpose is to expand equitable access of integrated and comprehensive NCD care within primary healthcare. And that is very important. We cannot address this over, the data that I've just shown, which is so dire, with a continued siloed approach. So we're trying to strengthen the capacity of health authorities to implement comprehensive NCD services, to increase the capacity of primary healthcare services to deliver quality NCD screening, diagnosis, treatment, and continuous follow-up, and to strengthen data collection and monitoring. And this is the visual that we use. We center it at primary healthcare centers, and as you probably deal with your patients, they come in not with one condition, but with several conditions. And how do we provide a people-centered care with the multimorbidity that we have? So the idea is that we can strengthen the capacity of ministries of health to accomplish that. And it has six strategic areas. Countries need to have plans for scale up and expansion of NCD care, which would include telehealth. There should be a component on community outreach and participation in NCD services, normative NCD guidance and quality improvement. I'm going to spend a little bit of time on number 3, the primary healthcare workforce development, expansion of essential NCD medicines and technologies, and the improvement of NCD information and monitoring. So this is another visual how we're trying to re-engineer and to help ministries of health better deliver that care. So one of those initiatives is precisely the HEARTS. So I hope some of you may have heard of the HEARTS initiative. It is implemented now in 33 countries in the Americas, and we've had some advancement in Bahamas as well. In the Caribbean, as of today, 18 countries and territories are implementing the HEARTS initiative. And this is how we put into action our approach to addressing this, the major NCDs, starting with the HEARTS, which is centered at the primary healthcare center, and which I will devote some time to talking about what we're promoting in terms of clinical care pathways and adopting a quality improvement approach, and which is solidly based on having data quality in order to monitor the work that is being done. So what are some of those goals that we have, for example, through the HEARTS initiative on the hypertension aspect, is that we would reach 80% of people to be diagnosed. Among all of those, 80% should be treated, and among those, 80% should be controlled. And that would take us to a 51% of population control. It's not, it's not the totality of the population yet, but we know that even with modest changes on hypertension control at the population level, we're able to decrease ischemic heart disease as well as stroke mortality. So this is one of the actions that we are taking from PAHO and promoting this initiative. We have been also working towards the implementation of care pathways, initially with hypertension and then also with diabetes. And I'll describe that a little further. We consider that guidelines continue to be very important, but it's also very important to implement those clinical guidelines. Therefore, we have been investing quite a bit on clarifying conceptually that yes, guidelines synthesize and analyze the evidence and offers rigorous frameworks for decision making, and they have a place, and therefore the World Health Organization and PAHO also devotes resources to the work of development of global hypertension guidelines, for example, and in the works right now is the development of a hypertension clinical guideline. But at the same time, we need to have clear protocols, which is the way to implement the guidelines recommendations in a standardized way. And furthermore, incorporate those protocols into actionable clinical pathways. Therefore, the HEARTS promotes and works with countries to develop their own clinical pathways based on the medications that are available at the country. And you will see that almost every country has developed their own clinical pathways. We're also working on integration of hypertension and diabetes, and therefore HEARTS also serves as a tool. And this is the future. We hope that clinical care pathways can be developed for all conditions to facilitate the work of the teams, of the healthcare teams. And at the moment, I'll go a little faster through this, and also please, I'd be happy if you can show me time. I cannot see here the messages if how much time I have left. But
You have about 2 minutes.
Okay, so we are moving towards a HEARTS 2.0, and we hope to be sharing with you this new methodology. As of now, throughout the Americas, we are covering 16 million people that are in the catchment areas, and those are reaching a control of hypertension of 66%. This is all throughout the Americas. So we saw hypertension as the entry point, and then we are continuing on with diabetes. And we're also adhering to the global agreements that we've made around diabetes, similar goals and targets. 80% of people that have diabetes being diagnosed, of those, 80% achieving good control of glycemia, and of those that are diagnosed having good control of blood pressure as well. 60% of people with diabetes over 40 years of age receiving statins, and 100% of people with type 1 diabetes receiving affordable insulin and glucose monitoring. So there is a lot of work and resources as well in the area of diabetes. And I want to just get to show you that we're also working towards the development of those clinical pathways for diabetes, working with the countries. And let me arrive to that so that we finalize with a visual of what that action may look like. So again, these are actionable clinical care pathways for the primary healthcare team, and we're developing with countries to advance the care in diabetes. We look forward to working with the countries, but also people have access to all of our resources on our website, and they have been geared towards not only to ministries of health, but also to healthcare facilities. So this is all available. So that I won't exceed my time, I would leave it there. And what we're looking to do is to transform the healthcare model that we have. And that is what the overall Better Care for NCDs is looking to do through the HEARTS initiative, as well as through the HEARTS-D and the diabetes programming that we're offering from PAHO. Thank you very much, and I appreciate your time.
I want to thank you, Dr. Raldo, for a well-informed and well-timed presentation. I'm going to take a bit of a liberty here and ascribe all that you talked about as a metabolic syndrome, as a cluster of syndrome with non-communicable diseases, hypertension, diabetes, obesity. So I'm going to ask you a public health question, then I'm going to ask you a clinical question. The focus seems to be on treatment. Is there any focus on prevention? And the clinical question is, what would be the impact of the new weight loss drugs such as GLP-1s and bariatric surgery?
Okay, so because I didn't want to exceed on time, but there was an entire part of the presentation that and I'm not going to go. I just wanted to show you the visual. Of course, we need to look at the risk factors, and of course, we have to work on the prevention. So there is a whole area at PAHO that we work on tackling the risk factors, and we do that through what is called the best buys. And the best buys are the most cost-effective interventions that have been studied. And I wanted to show you just the visual. These are dosed, for example, around tobacco, around alcohol, around healthy diet. And the part visible here is our English-speaking Caribbean, and we're not doing so well. But we're going to keep working very hard with our ministries of health, with the civil society. So to answer your question, there is a whole plethora of interventions for the prevention side. So because I listened to the first part of today, it was mostly a clinical audience. I focused on more of the clinical audience. For the second question, so I am not a clinician, but I can tell you that there will be novelties in the new WHO diabetes guidelines that will be coming out. It's WHO PAHO diabetes guidelines that will be coming out early next year. And there will be inclusion of some of the latest generation medications. But that will be, I'll be happy to speak about that or invite one of our clinicians to speak next year.
All right, thank you. So I'll open up the floor to questions.
May I?
Go ahead.
Yeah, I'm Dr. Bloomfield. Very good presentation. One of the problems that we seem to face in clinical practice is you pointed out the high rate of obesity in the Bahamas, especially among women. But social media now seems to have given people the idea that there's serious alternative besides taking good care of yourself and sticking to the guidelines, that there are supplements and different factors that are available that can suddenly make all of this obesity go away. And it's kind of hard to defend the regular treatment protocol. What I've seen over the last 5 to 10 years, bariatric surgery in a lot of the patients have not demonstrated the effect that we probably anticipated initially. Most of the people who had the bariatric surgery are probably as big or bigger than they were before the bariatric surgery. Now, with the new advent of medication, it's for us then to see exactly what impact it will probably have over the next 5 years before we can give some judgment. But social media is certainly playing a destructive factor in getting people to understand what they actually need to do. Thanks very much for allowing me the opportunity.
Thank you. Thank you. I mean, I think that's an excellent comment. And if I may add, I kept this slide here purposely because around a healthy diet, let me see if I can get a more clear one, but some of the best buys interventions that I was mentioning have to do, I know you were speaking about adults and female adults, but so much of those, maybe that narrative and that mind shift that we have as adults has been constructed through our life course. And therefore, some of our interventions, we propose strict marketing to children in schools, school nutrition policies, the banning of ultra-processed foods, or at least the banning of very many different types of unhealthy products from early age. So yes, and so imagine also what we're going to be facing as well with social media that not only affects adults, but very seriously affects adolescents and children. So yes, we have to have regulations around marketing, even online. I think, some more even in Europe or in other countries, there is now work around the marketing to children in the different environments, so not only the physical environment, but the virtual environment.
Yeah, that's an excellent point, because again, it touched on prevention, and we all know that metabolic syndrome starts as early as 5, 6, 7 years of age. So it does make a difference.
Yes, we need strong regulation. So we also need clinician allies that help us advocate for strong regulations in the different environments.
So if there are no more questions or comments, I would like to present our next presenter. She is Dr. Andrea Burrows, an SHO at the Princess Margaret Hospital here in the Bahamas, and she'll be talking about a complex AAA abdominal aortic aneurysm with a pelvic kidney.
Hi, good afternoon. My name is Dr. Andrea Burrows. Is everyone able to view the screen?
Yes, we can see and hear you.
Pardon, Dr. Tinubu?
We can see your screen and we can hear you.
Okay, thank you. I'll start. So I'll be presenting a case report on abdominal aortic aneurysm with an ectopic pelvic kidney and contained iliac rupture. This is the outline of the presentation. I have no disclosures. An abdominal aortic aneurysm is a dilation of all 3 anatomical layers, and the diameter of the aorta would be 150% of its normal diameter. In the US, the incidence is 1.4% of persons between the age of 50 to 84. Over the Caribbean, only Trinidad and Tobago had available statistics showing that it affects 4 per 100,000 persons per year. Risk factors for abdominal aortic aneurysm can be classified as modifiable and non-modifiable. Modifiable risk factors include smoking and hypertension, while non-modifiable risk factors include an age greater than 65 and patients with connective tissue disease. Patients can be asymptomatic unless it is complicated. When patients do experience symptoms, it can be abdominal or back pain or syncopal episodes. The risk of rupture depends upon the overall diameter of the aneurysm. So those less than 4 centimeters have a risk of rupture of 0%, while those greater than 8 centimeters have a risk of rupture of 30 to 50%. Indications for surgical repair include a complicated abdominal aortic aneurysm, and those that have a diameter of greater than 5.5 centimeters in men or greater than 5 centimeters in women, or an expansion of greater than or equal to 0.5 centimeters over 6 months or 1 centimeter over 1 year. Surgical options include open repair versus endovascular repair. So in open repair, the aneurysm would be opened and a synthetic graft would be placed to allow for blood flow, while in endovascular repair, a stent would be placed. So for the ectopic kidney, it is extremely rare in association with an abdominal aortic aneurysm. It affects 0.18% of cases. Common locations for an ectopic kidney include thoracic, iliac, and pelvic. And its blood supply can be derived from the common iliac artery, the internal iliac artery, or the distal aorta. Now to the index case, which was a 65-year-old male who was non-compliant on his hypertensive medications, had a lipoma to the left thigh for many years, which then became painful, leading to his primary care physician requesting an imaging study to be completed, which will be discussed later. The patient also had a significant smoking history of 1 pack per day for many years associated with ETH use. He also had a high cholesterol diet and no personal history of peripheral arterial disease. On examination, the abdomen was obese and soft with mild tenderness in the suprapubic region and iliac fossa with no organomegaly and normal bowel sounds. His laboratory investigations, he had a hemoglobin of 11, normal creatinine of 1.23, slightly deranged coagulation profile, but an elevated troponin, which was of concern, where he had an ECG completed, which showed that he had sinus rhythm and also a 2D echo. This is the imaging that the patient had completed. So here shows the abdominal aortic aneurysm. This is the blood flow through the aneurysm, and this is the collection of thrombus, so basically clots within it. This also shows the ectopic kidney, and this is the internal iliac artery, which also had an aneurysm. So the patient was assessed as having an abdominal aortic aneurysm, also with bilateral internal iliac aneurysm. So he was therefore admitted to the ICU, and the following services were consulted. He was also prepped preoperatively by having blood products on standby and also had the cell saver on standby in case of significant blood loss. During the procedure, a midline laparotomy was completed to ensure that there was full exposure. There was also infrarenal aortic clamping to control inflow and to minimize the risk of exsanguination. The renal arteries were also isolated and the kidney was resected. The kidney was also cold perfused to help with its preservation. This is an image of the ectopic kidney. This was its renal arteries, the renal vein, and its ureter. When the aneurysm sac was open, this was the thrombus and debris that was collected within it that was evacuated. Then we placed a bifurcated Dacron graft and the clamps were removed and flow was reestablished. The kidney was then retransplanted and its arterial supply was connected to the right common femoral, the venous supply connected to the inferior vena cava, and the ureter was reattached to the bladder. Post-operatively, the patient was initially stable, but overnight, then required inotropic support and had an elevated in creatinine and was now oliguric and now required renal replacement therapy. Post-op day 5, unfortunately, the patient demised suddenly and had a post-mortem completed which showed that the transplanted left kidney was healthy, but the native kidney appeared to be shrunken and mottled. The pathology suggested the patient likely demised from a myocardial infarction. The overall risk of mortality with patients with a ruptured abdominal aortic aneurysm include 80 to 90%, and post-surgical intervention, the chance of mortality is still 35 to 50%. Some predictors of mortality include elderly and hemoglobin less than 10, increased creatinine, syncope, and cardiac arrest. So after a review of several academic databases, there have been no reports of a ruptured abdominal aortic aneurysm with bilateral internal iliac aneurysms with an ectopic kidney. But there have been slightly similar cases, such as in Japan, a 91-year-old female with hypertension presented with a pulsatile abdominal mass, had a CT completed which showed a 6.9 centimeter infrarenal abdominal aortic aneurysm with a left ectopic pelvic kidney. She had endovascular repair completed, a hospital stay of 19 days, but no postoperative complications. Another slightly similar case was a 71-year-old male smoker who also had an abdominal aortic aneurysm, whose CT showed a 5.8 centimeter abdominal aortic aneurysm, also associated with cross-fused renal ectopia. He had an open surgical repair completed, a hospital stay of about 7 days, and no postoperative complications. So in conclusion, a ruptured abdominal aortic aneurysm has a high morbidity and mortality. The incidence of ectopic kidneys are rare, and this also made the case more challenging, but the case adds to literature and will assist with managing future cases. These are my references. Thank you.
Okay, I'll open up the floor to comments and questions. I just have a quick question. Was this patient a candidate for endovascular repair? Why or why not?
No, sir, he wasn't a candidate for endovascular repair because the size of the diameter was too great to place a stent. He needed the open surgical repair.
Okay, I welcome any other questions or comments.
Hi, Dr. Tinubu. This is Dr. Lucas.
Go ahead.
Thank you so much. And thank you, Dr. Burrows, for presenting that case. A very unique case. And just to answer your question, one of the things that we're working on as a department and vascular surgery, Team A, we're trying to provide more endovascular options for our patients, as you mentioned. This particular one would be a challenge in terms of the anatomy. But the real challenge we have is getting, the devices we need in a timely fashion. In another case report, case series that we will present, we talk about our dissections and the timeline to get a stent into the Bahamas to actually save a life is almost 2 to 3 weeks, which is totally unacceptable. But we are making a lot of strides to improve the quality of care that we can offer. Especially exemplified by this case, the patient presented with significantly elevated troponins, which can suggest cardiac strain preoperatively, and then also because of the strain of the surgery, postoperatively, the third-day mortality is quite high. We have Dr. Morris and others who joined and bolstered our cardiology department, and we're hoping to make strides in a combined cardiovascular clinic and to improve the care for our patients. So thank you for presenting the case.
All right, thanks, Dr. Lucas, and thanks again, Dr. Burrows. Our next presenter is going to speak to us about a retrospective study of venous duplex ultrasound scans in the Bahamas. His name is Dr. Brandon Griffiths. He works out of the Queen Elizabeth Hospital in Barbados.
Good afternoon, everyone. You hear me? Good
Yes,
afternoon.
we can hear you.
Good afternoon. My name is Dr. Brandon Griffith, and presented today the topic of a retrospective cohort study of venous duplex reflex scans in Bahamas, illuminating venous disease. I do not have any conflicts of interest or disclosures. So what is detection of venous reflux important, or what is a venous reflux duplex scan? To understand this, we must do a quick review of physiology. Peripheral venous system serves as a channel for returning blood to the heart. The patency of veins, valves, and muscle pumps is necessary for venous system to function properly. To return to the center of circulation, blood must travel against gravity and other pressures in an upward position. The veins in the lower extremity are as classified superficial, deep, perforators. Perforating veins traverse the fascial layer, connecting superficial to deep veins. A number of one-way bicuspid valves through the deep and superficial veins allow blood to travel toward the heart while preventing it from returning to the feet. However, in venous reflux,
can I interrupt you to progress the slides?
Pardon me?
You're still on the first slide.
Correct, yes.
Okay, fine, okay.
However, in venous reflux, there is a reverse in this flow, often due to incumbent veins and valves. Venous reflux is the most common cause of venous hemodynamic disorders leading to chronic venous insufficiency. So the venous duplex reflux scans is considered gold standard for diagnosing venous reflux, offering high sensitivity and specificity in identifying incompetent venous segments by inducing reflux and visualizing flow patterns. So the second point, there is limited data on patients with lower limb venous reflux and chronic venous insufficiency in Bahamas, the Caribbean region, and Afro-Caribbean populations as a whole. Therefore, the aim of this study was to identify the local venous disease profile, highlighting the demographic group, symptomology, patterns of venous reflux, and valvular incompetence. So this study was designed as a retrospective cohort study of 214 patients who underwent scans from January 2024 to July 2024.
Sorry to keep interrupting, but your slides are not progressing.
You haven't seen them progress?
No,
Can you see it?
it's not on slide presenter more. We could just see the first slide. Just the title slide we can see.
Oh. Sorry. Can you see it now?
Yes, we can.
All right, thank you very much. This study was designed as a retrospective cohort study of 214 patients who underwent scans from January 2024 to July 2025. The data identified was analyzed, exploring clinical variables and scan findings. Though there were 214 patients, 351 lower limbs were examined, 33 right only, 44 left only, and 274 bilaterally examined. In this demographic, the mean age was 52 years, with the majority of patients presenting from age 40 to 60. Females were noted to make up 61.8%, and males were 38.2%, giving approximately a 2-to-1 female preponderance in this presentation. Here, we are highlighting the chief complaint at presentation, where 53.27% was swelling, 14.95% was varicosities, 12.15% had chemo, and 6.54% had ulcers, and 3.2% were post-operative vascular surgery. However, as we know, all patients do not present in an isolated box of only having one symptom. There was a total of 33 patients who had varicosities, and 32 out of the 33 patients, varicosities were the chief complaint, highlighting a low threshold for seeking professional care with this sign. Similarly, to the patients of lower limb swelling, 112 of 114 swelling was the chief complaint. Now, please pay attention to the pain on this chart as we move on. So look at the pain. So on this next slide, we are exploring symptomology as a whole. We observe that there's an overlap in symptoms, most notably the complaint of pain, whereas the chief complaint, pain only represented 15.42% in this population. However, 30.37% of the patients were experiencing lower limb pain. This raises an interesting question of patient attitudes of urgency of lower limb pain in relation to other symptoms. Even though this finding may be coincidental, a higher power study and patient-centered questionnaires may elucidate the presence and attitudes towards pain, and it's worth reporting as a chief complaint. In this study, 102 patients had varicosities where bilateral distribution was most common, with a near even distribution of size and unilateral findings. These varicosities were found on scans and not by the patients themselves or upon examinations. As was previously mentioned, patients found with varicosities were the second most common reason for presentation. In terms of venous involvement for varicosities, the great saphenous vein was the most commonly affected at 87%, followed by small saphenous vein at 41%. If you pay attention at the image on the left and the lower limb on the left, it shows you the segments of the great saphenous vein. In this demographic, the distribution of segmental involvement for the great saphenous vein was often seen along the entire length of the vein, with some isolated to the middle and distal segment, and even less in the proximal aspect. Globally, we often see involvement primarily the mid to distal aspect, revealing to us the extent of disease in this cohort, given the entire segment being involved. As it relates to the clinical part of the C classification, for chronic venous disease, majority of patients presented with C3 disease and above at 59.81% of this population, with the most common presentation being edema. Venous reflux can be subclassified into sustained and non-sustained reflux. Sustained venous reflux refers to continuous backward flow of blood in the venous system, typically lasting more than 0.5 seconds. And this indicates significant valvular incompetence in the superficial or deep veins. Non-sustained venous reflux, on the other hand, is a transient backward flow that lasts less than 0.5 seconds during testing. It may be less indicative of significant venous valve failure, however, sometimes found in normal individuals, or it may illuminate early stages of venous disease. We saw that reflux was identified in 206 patients, which is essentially almost the entire cohort, with 80.53 having sustained and 19.42 non-sustained reflux. Valvular incompetence was identified in 134 patients, with majority of cases seen unilaterally. We noticed that 2/3 of the patients with unilateral valvular incompetence had right-sided disease, and lower limb valvular incompetence is generally more common seen on the left side, primarily due to anatomical factors that put pressure on the left common iliac vein, which will lead one to wonder what factors may be in play within this specific group, causing a trend to right-sided disease. In this study, we observed a mean age of 52 with higher prevalence in women consistent with global data, showing women are more prone to venous insufficiency due to hormonal, genetic, and lifestyle factors. The most common finding being lower limb swelling, which is the most common finding in chronic venous insufficiency. We as physicians should identify early symptoms such as swelling like discomfort, fatigue, and itching. Although there can be variations in the presentation among patients, certain features are more prevalent as we see here. If routinely screened for these symptoms, a lower threshold for referral can be established with early intervention. This means having a vascular center and accessibility to vascular techs who can help expedite or streamline management imperative. Nearly all scans identify reflux, emphasizing its pivotal role in venous pathology, specifically sustained reflux, which is considered hemodynamically significant, contributing to elevated venous pressures and clinical symptoms. Additionally, the distinction between sustained and non-sustained reflux helps stratify disease severity, guiding management decisions. The most frequently involved vein segments with the great saphenous vein in 85% of cases, aligning with established literature that reports great saphenous vein incompetence as a primary contributor to varicose vein development. Notably, bilateral involvement with patients exhibiting reflux highlights the importance of comprehensive bilateral assessment. Further prospective studies are recommended to explore risk factors such as obesity, genetic predisposition, and lifestyle that influence our reflux patterns. There also is a need for development of local management protocols tailored to observe patterns to optimize patient outcomes. So in conclusion, this study provides a comprehensive overview of venous reflux patterns in the Bahamian population and Afro-Caribbean population, which is often underserved in literature, which has highlighted key similarities and differences to global findings. They also showcase the importance of duplex scanning and its relevance in the region, underscoring the need for increased awareness and early intervention strategies to improve patient detection and also outcomes respectively. Involving patient-centered feedbacks and perspectives of their symptoms is also very important. As these scans are continually performed, we will collect necessary data, setting the foundation for future research, striving to make Bahamas healthy again. These are my references, and I would like to express my sincere gratitude to all those who supported and contributed to this research. And thank you all attendees.
All right, thanks for your talk on the duplex. I have one quick question before I open the floor up. What are the clinical implications of getting these scans done? Because when you look at the CEAP, we base most of our management on the clinical aspect and not the investigation aspect of it per se.
The clinical implications is that sometimes patients may not have overt signs that are not identified by us. So if we open the floor for screening questions when we have patients in front of us or in certain groups such as diabetics, hypertensive, obese patients, and even women over a certain age, that opens the floor for us to now screen for these symptoms that they may not see as significant. As shown in the research, a lot of these patients had pain, but never reported pain. And we know pain could be something as sinister as a deep vein thrombosis. So us having that lower threshold for asking these questions could identify earlier stage disease, meaning that even though we don't see something that's extremely overt, we could then refer them for these duplex scans, which could help prevention of progression of early disease in itself.
So with that, I invite any other questions or comments from the floor. If there are no further comments or questions, I would like to introduce our next speaker.
Testing.
Who's going to speak? Yes, we can hear you. Okay, so I would like to introduce our next speaker. He's going to talk to us about pacemaker implantation.
Sorry. I am a female.
Sorry.
That's okay.
She. Yes. And your first name is Rogel.
Rogel.
Yeah. So Rogel is an internist, and she works at University of the West Indies, Bahamas. Adult cardiologist, cardiac electrophysicist, who recently completed her advanced fellowship in adult cardiology. And I hand the floor over to you.
Thank you so much. Can you guys see me and see my presentation? Perfect.
We can see you, but not your presentation at the moment.
Okay. I think Dr. Halliday is going to work his magic. Excellent. So good afternoon, colleagues. Thank you for that introduction. I'm a cardiologist and a cardiac electrophysiologist at Princess Margaret Hospital. And today I'm going to be sharing a case that not only tested our clinical readiness, but helped to restart pacing capabilities at PMH after an almost 2-year gap. And what began as a life-threatening emergency became a story of teamwork, innovation, and system renewal. So my goal today is to show you how guideline-directed care adapted thoughtfully to our Caribbean context, and it can save lives even when resources are limited. So I have no financial conflicts of interest related to this presentation. I'm not affiliated with any device or pharmaceutical company. All interventions were performed as part of standard care at PMH, and this presentation is for educational purposes only. So pacemaker malfunction is a true cardiac emergency, and according to the 2023 Heart Rhythm Society and American Cardiac Society guidelines, immediate pacing is a class 1 recommendation for stable, complete heart block. And in many developed centers, that is straightforward. So you get pacing wires, you have pacemakers implanted, there are interrogators available, there's technical staff, all on standby. But in the Bahamas, where electrophysiology services are still emerging or starting to emerge, this was not the case. So our last public sector implantation was about more than a year ago. So our rationale was twofold. First, to save the patient's life, and second, to reestablish our hospital's capacity to manage device emergencies safely. So my case presentation is a 70-year-old female who's hypertensive, and she presented with a prior history of a pacemaker being implanted in 2020, and this was for complete heart block. She actually presented with palpitations, shortness of breath, and fatigue, and near syncope. And when she initially presented, she was actually normotensive, but then within a few minutes, her blood pressures fell and her heart rate slowed dramatically. And this was her ECG on presentation in the emergency room. So on arrival, so notice that she has P waves. They're all marching through independently. I don't know if you can see my arrow here, pointer. Can everybody see? Okay.
Yes, we can. So
they're just P waves kind of marching through all the way through. Let's go down here. P waves marching through. So her heart rate was actually 35 beats per minute. And there was AV dissociation as well as a ventricular escape rhythm. And this confirms a diagnosis of complete heart block. and is actually with somebody who has a pacemaker in situ. So clearly her pacemaker has failed. And this is actually a life-threatening situation, especially for patients who are pacemaker dependent. And I think she probably was. And at this point, she was hypotensive, symptomatic, and at risk for cardiac arrest. So this ECG actually became a turning point. It was set up for urgency conditions where we wanted to restore pacing in the hospital. And unfortunately, we actually had no temporary pacemakers or pacing wires available. So what did we do? Because we had a lot of multiple system challenges. There were no pacing wires, as I said. There was no device interrogator. And the patient actually didn't know what type of pacemaker model she had. And there was staff with limited experience managing device failure. So these are all realities for many of us practicing in resource-limited Caribbean settings. And the challenge wasn't whether to follow guidelines, but how can we uphold their intent when resources are limited? So we applied these principles. We restored her rhythm safely, we preserved dignity, we communicated clearly, and we adapted evidence-based care in our environment. So as it related to having no pacing wires, luckily I actually had one available in my personal source, and there was no interrogator available. There's actually one sourced from the doctor's hospital. And then finally, with doing some ways of deduction, we eventually found out that she had a particular model for her pacemaker and got the interrogator specific for that. And this just kind of highlights that we have a lot of system gaps, and we need to do more interdepartmental collaboration and inter-hospital collaboration as well. So according to the Heart Rhythm Society recommendations, an unstable complete heart block requires immediate transvenous pacing. Is actually a class 1 indication. So as I said, I got a wire from my personal stock, and then we proceeded to the operating room where we placed a temporary wire under fluoroscopic guidance. And we did that to avoid dislodging her leads because we weren't aware of what her lead status was. So as soon as she had her temporary wire placed, she actually became hemodynamically stable and her symptoms resolved, that being of near syncope. So this demonstrates that guideline intent can still be met as we acted decisively and safely, even under constraints. So finally, we were able to get a device interrogation, and we also got an old device, her previous interrogation report, and that showed that she had a device that showed a RV that was failing, and she had chronic high output pacing from the right ventricular lead. So with this, we then deduced that she probably had premature depletion of her battery for her pacemaker because her RV lead was taking a lot of energy. So this just shows you what her last interrogation report was, showing that her thresholds were very high. And her ventricular threshold is actually just reading high. Usually you have a number. And then her pacing output was pretty high at 5 at 1 millisecond, which is pretty high. So we proceeded to the OR the following day, and she actually had a new right ventricular lead placed. After we put in the right ventricular lead, we realized that the right atrial lead had also failed, and then ended up putting in a new right atrial lead, and then we replaced her pulse generator for her device. So essentially ended up requiring a new dual chamber pacemaker system. And during the procedure, we kind of discovered that. And this procedure was led with invaluable assistance from my colleague, Dr. Charles Lucas and Dr. Farquharson, whose expertise were essential in establishing safe vascular access. And then this collaboration kind of marked one of the first hospital pacemaker implantations in over 2 years, and symbolized what was possible when we have both EP and surgery working together. So we had a great outcome. The patient's pacing parameters were excellent. She became hemodynamically stable. We were able to remove her temporary pacing wire. And post-operatively, it showed that she had obviously her 2 old leads inside you. So this just shows you what we did inside the operating room. So she has two old leads, 1 atrial and 1 ventricular. And we put in 2 new 1 atrial and 1 ventricular leads, and then replaced her generator for her pacemaker. And her post-operative chest X-ray confirmed that the leads were positioned well and she had no complications, including a pneumothorax. And she was actually discharged quite safely on the following day. And she received thorough education as it relates to device care and the importance of follow-up. And she was seen she has a nicely healing scar, and we'll see her in a 6-week follow-up for her wound review and interrogation to see how her 2 wires are doing and to see how her pulse generator is. So this is just some pictures of the team on that day. So we actually got somebody come in to help us with programming the device. And that's myself and Dr. Lucas doing the procedure, just some instruments, and just a picture of the actual device itself. So from a discussion perspective, this case underscores several lessons. Clinically, we must recognize device failure early and improvise safely when resources are constrained. Systemically, we actually need device registries. We need regular interrogation schedules and better coordination between public and private care, and regionally early referral to electrophysiology to prevent crises like this occurring again, and then, being predictable and managing interventions safely and early. So key takeaways from this. So early recognition, as I said, and this actually saves lives. And if there's one thing you remember is that innovation bridges the gap between systems until the system actually catches up. And collaboration between multiple teams or multiple systems allows us to make progress and allow it to be sustainable. And that is leadership kind of begins with a decisive act. And this case represents just one of many interventions electrophysiology brings to our patients. And my hope is that it marks the beginning of a renewed, accessible pacing program for the Bahamas. So just want to acknowledge part of that team, Dr. Farquharson and Dr. Lucas. And this was truly a shared success for our patient. And these are my references. And thank you. I look forward to collaborating as we continue building electrophysiology capacity for our patients. And that's how you can reach me. Thank you.
Thank you, Dr. Morris, for quite an informative talk. It's quite relevant in our resource-restrained or constrained environment. With that, I would like to open up the floor for any comments or questions. I see a hand raised, yeah. Dr. Senkwi.
Hi, good afternoon. Thank you very much for the presentation. Just wondered, what was the reason why the patient did not have a plan after the device was showing that it was at end of life? And, I just wondered if you had explored the information from her as to, what happened to her, because chances are we may be faced with the same problem again with the new pacemaker.
Yes, thank you for that question. Very important question. So I don't know all the details, but I do know that her device, in terms of her right ventricular lead, was failing since 2022. And I presume the conversation had begun in terms of, we might need to replace your new right ventricular lead. But I'm not sure if this was related to financial constraints or what it might have been due to. I'm not sure.
And also, just as a note, I mean, I am aware that we have done lots of pacemakers throughout the years, And so even though the pacemaker, you were successful in doing this one in the public hospital system, and congratulations on that, that I don't think patients were denied access to having their pacemaker devices replaced, as far as I know, because there
agree.
have been public-private partnerships, so that I don't think that there has been a failure in that regard in providing pacemaker services for the country.
Yes, I'm aware of that, and I do agree they're never denied. But I'm not sure what her reason for defaulting, because her last device follow-up was in 2023, and at that time she had no, her threshold was just reading high, and certainly for myself, that kind of raises a red flag for me in terms of immediately that's somebody that I would want to tell them or establish a close follow-up, and let them kind of know, especially if their device, if she's dependent, especially in her case. I think based on her interrogation from 2023, she was actually pacing more than 80%. So it shows that she was dependent, and she pretty much relied on her right ventricular lead. And essentially, for somebody who has a high threshold, certainly that's somebody I'm going to be following, almost feeling like it's a weekly basis, or even monthly basis, where I'm bringing in or I'm planning for her new right ventricular lead and replacing her battery, because I think at that time her battery was only 1.5 years left. And when I did the interrogation in hospital just prior to her device being placed the following day after we sourced an interrogator from Doctors Hospital, essentially her battery died April of 2024. So she was pretty lucky to have survived with complete heart block for almost 1 year.
All right, thank you again, Dr. Morris.
Thank you so much. Thank you for having me.
You're welcome. Our next presenter is Dr. Patrick Toppin. I think he's a Bayesian who now lives in Jamaica, also spent some time in Trinidad, and is now presenting in the Bahamas. He's an anesthesiologist and a critical care doctor who practices at the University Hospital in Jamaica. And he was going to talk to us today on the use of basic machine learning techniques in guiding healthcare decisions.
Good day, excuse me. I had a question for the previous speaker, please.
I guess you can go ahead if she's still with us.
Okay, I put it in the chat. This is Dr. Hannah. I was wondering whether transcutaneous pacing was used as an interim measure within the ED for that patient as they were attempting to do the transvenous.
Hey, thank you for that question. So I forgot to put it in my presentation. So yes, she did have transcutaneous pacing. When I arrived to see her, her transcutaneous pacing was actually not capturing. So she was not capturing. And then when I was seeing her for a few more minutes, it was intermittent capture as I increased the output. So it wasn't very reliable at all. And she was near syncopal. Her blood pressures had dropped right before my eyes. So we had to put in a temporary pacing wire. Thank you for that question.
Thank you, Tim.
Apologies, Dr. Toppin. So I guess we can go ahead with your presentation.
Good afternoon. Pleasure to be here. Thanks for being in the invitation. Are you seeing my slides?
Yes, we are.
Okay. So I'm gonna say I jump off and say I have no disclosures. I'm gonna try and explain a little bit about what is a big watchword in medicine, in life, modern day life, AI. I choose to focus on the related machine learning, give some specific examples, and then maybe suggest some things that we as a region need to do to kind of jump on board with this. I'm going to start with some definitions. This one is pretty simple, artificial intelligence, and it's a machine or computer that's made to simulate human consciousness. And these are some of the features that you might want it to do, to be able to plan, to perceive, to recognize something, to reason, and then make decisions based off of available data, and to be able to communicate that, whether it be writing, verbally, in images. And I'm going to divide this huge area into narrow AI, which is about almost everything that we have used in modern day, which is very focused on a specific task, answering a specific question, and it can be very good at that very narrow specific area. It does require some guidance, some setup by what do I want to call it, a programmer. And then what we fear, which is a general, or to use this term, strong AI, which has lots of information stored in and kind of thinks like a person does. It can come up with ideas. It can respond to completely new challenges on its own. And that's still a way away. So most of what we're doing in terms of this narrow, weak AIs, we can call machine learning. And the difference, or how I would try to define machine learning, is there are different ways that we use computers to try and learn from data without being explicitly programmed. So I may give the computer some guidelines, so just general rules, and then the computer is free to try and come up with answers. Within these rules, you try and figure out if this man has cancer, if this guy is going to buy your products on the screen. The computer is free to come up with that decision, make a decision. So that's machine learning, and that's the vast majority. So I focused on that because that's the vast majority of what we see and utilize in real life. I'm going to divide machine learning now, trying to make this understandable, hopefully. And we're going to say there are two types, two big areas machine learning can be: supervised. And this is probably the biggest part of what we do. Supervised means someone has gone through and labeled. So it may be that I have, using a medical example, I have lots of cases of images of CT scans, CTPAs, and I've gone through and labeled them. This one is a PE, this one is not. And then I've given this information to the computer and said, you figure out the rules that would allow us to say an image has a PE or not. But it requires supervision or labeling so that the computer can then work backwards and say, I'm going to make up some rules that will allow me to make this prediction. Now, the unsupervised models, not used as widely, but in unsupervised, what you do is you give the computer some data and say, figure out patterns, figure out connections between these groups of data. An example that we use in my field, for example, critical care, is we've used this to identify clinical subtypes of people with sepsis. Things that maybe weren't so obvious to us, we'll put in this information and say, hey, figure out 2 or 3 groups. And what are the factors that would allow us to make that classification? So the other name for unsupervised learning, and I'm going to give a specific example, which will hopefully help, is clustering. So you say, within this data, figure out which are 3 groups based off of all the different parameters you've given. Now I'm going to mention deep learning, and we'll call this a neural network, just because within machine learning, these models are the most efficient. They're the most efficient, but the biggest problem I have with them, and everyone, is they're what we would call black box models. Meaning some information is going to come in on this side, the input side, and then a decision is going to come out on the other side. And what happens between, I couldn't tell you. But it might come out and say, yes, this gentleman has a PE, this gentleman has cancer, this gentleman will have a heart attack, whatever parameter is. So it's not as, understanding how it reached is not clear at all. All right. Hopefully I'm nearing the end of the definitions and trying to explain these ideas, and we can do a couple of specific examples using these ideas. And machine learning now, with these different methods, you can also do what we'll call classification, which is identify a group. Say if my patient will buy my product or not, or your customer, or say if this patient will have a heart attack, develop diabetes, develop a cancer, and regression is more to predict a number. So a regression might be predict what this patient's hemoglobin will be, predict what this patient's blood sugar will be. So it's a specific number, a continuous parameter versus figure out which group these people belong in. I mentioned generative AI. It's not a big part of what I'm gonna do, but it dominates so much of the space of what we do when we think of AI machine learning. Generative AI can actually create new content, whether it be images, text, music, audio, and it learns. It requires a huge amount of data, and they're actually predictive. So examples, if you use your chat GPT, your large language models, whichever one you use, what it does is look at previous data, and it actually is predicting what words will come next, what word would come first, second, and it's trying to figure out, based off of this huge amount of data it has. Problem with this, which you may see if you use it a lot, is you get some hallucinations, meaning it makes up words. This is not the one I get in doing medical literature searches, is it makes up citations. It makes up a reference, and the reference may look good. I recognize these authors, and this is an area they're published in, and that sounds like a title they would use, but it doesn't actually exist. So I'm always checking back, because it's just based off a prediction. So I put these all together. Hopefully this artificial intelligence is the big catch-all with everything in it. I've chosen to focus on machine learning, which is a way we use to help our computer help us make specific decisions. And a subset of that is the deep learning, which is that black box neural network that I mentioned. Okay. What's important with all this? And this is important in terms of recommendations. This is built on data, lots of data and good data. People use the term big data, and this is a definition you can use. It exceeds the capacity of a traditional method to store, manage, or process. If you think of it as the idea of as your computer, I could be trying to work on a data set that cannot fit in my RAM, which is the working memory of my computer. It is bigger than that. So there are different techniques I could use to try and look at it at different times. So the size of the data adds to how good our results are, but it can make it harder for us to use it. And I'm going to focus on the medical part, but there's tons compared to, even 20 years ago, there's a lot more data out there. Electronic health records. In Jamaica, we've started stepping into this. It's still a work in progress. There's a couple of hospitals, some government and the university hospitals, some of the private hospitals that utilize electronic medical records, which would be when they're up and running and capturing lots of stuff, are a tremendous, easily accessed source of data. Big part of health is wearable technologies. This is stuff, a phone, if you're wearing a watch, or this is a wearable ring, which can keep track of stuff like where you are. If it keeps track of where you are, it can keep track of where you've been, how fast you moved. Based off of stuff like heart rate, temperature, it can get ideas about sleep, how you sleep. Some of them can do some simple ECGs, at very least keep your heart rate, oxygen saturations. So these fairly simple devices can provide a tremendous amount of data, and I would suggest that this can be pretty invasive and pretty private data. And if you want another level of privacy is your genes. So genes, as we've had advances in our ability to measure genes and associate them with different diseases. We're still in early phases of that. And I would say within our region, we actually lack good data on what genes cause, for example, different kinds of cancer in our population. There's lots of good data on better data with breast cancer, for example, in North American and European populations, not so much here. And genetic data is huge. A gene, there's so many genes. We've identified a relatively small number of those. But if I had this genetic data and I throw that with my electronic medical records, I could, there are genetic diseases like sickle cell, but there are some genes we don't understand that may alter, increase or decrease the risk of a cancer. It might identify that this person is not going to respond to this medication, and this person is actually going to respond to this other lesser known medication. So if you're talking about precision, personalized medicine, genetic data would be where it's at. So I wanted to show some specific examples of using this. Hopefully this is not too, but the steps in doing machine learning, you would have your data, you would clean it up, organize it, and then you're going to split it into what we'd call a train and a test set. Testing is a big part of your machine learning, and you determine what's the best way I can set up my model. So you develop the model with the train set, and then that subset, maybe 20-25% of the data that you do not use for developing the model, you test it on that. Say, how good was it in predicting if this patient had cancer, if this patient had a PE? And I would adjust my model and go back and forth until I get the best model. And then I would put it out there and start using it in real life. These are some specific cases. I'd actually planned to use some local violence-related data, but there were some issues with the permission, and I have conceded, and I've used some examples from the literature. So this is an unsupervised technique. So this is why I told you I might put a set of data in and say to the computer, tell me what patterns you can figure out. How can I link these groups? And it might be something it's not so obvious. Say I have 50 different parameters or 10, whichever it is. So in this example, and this article actually contains several examples, but the one that I thought applied to this was they were looking at melanoma cancers, skin cancers, and they used 3 different unsupervised or clustering techniques. And they said, find us different ways. Let me, is the pointer. So this, the k-means clustering actually was the best, and it identified 4. And this is just a simplified representation of what it does. This only has 2 parameters, but in reality, I think they started with 10 different parameters, but it identifies 4 different groups. And they've given this to a computer, and what they're then checking back to see based off of what they know already. And the computer was able, just off of the data, to identify what is called 4 different clusters based off of the level of risk and recommendations. It came up with cut points for the size, how they looked, specific things we could identify. So this is not super novel, meaning we had already figured this out. But if I was starting with a new set of data, a different population, it strongly suggests that at least as a starting point, we could dump this data into this algorithm, an algorithm like this one, and start off knowing who was going to have problems and who was not, and quickly risk assess based off of specific things for your patient. This is another pretty famous, it's a PIMA Native American data set, and it looked at young Native American women, age, body mass index, peri-pregnancy, and the risk of diabetes. As in, so pedigree of diabetes is whether you had it, number of family relatives that have it, number of times you've been pregnant, blood pressure, and class 0, 1. 0 is no diabetes, 1 is no diabetes. And this is a specific machine learning model that I used. This is called a decision tree. And I thought this is a very explainable. So you could look at it and see what we're doing. So it starts off by asking, what is your glucose? And I won't get into the nitty gritty, but it measures a certain factor, and it looks to determine by asking and answering question, which question best organizes the data. into diabetic or not diabetic. So you go down, you'd ask, is your glucose less than 117? Yes, you would go here. Diabetes, this is a measure of family. They have a cut value of 0.6, which is a value of how many family members you had, and it would true or false. So this is false, false. Measure your insulin levels, number of pregnancies. If they're less than 2.5, so this is the average, one of the limitations, because you don't have 0.5 of a pregnancy, and then it would say you're not diabetic. And you could go down with each patient and go through and decide diabetic, not diabetic. And this has while decision trees are super explainable and it's obvious what's going on, they're not that accurate. So the accuracy was only 82%, sensitivity was 88%. So what we use a step up is different types of ensemble models where instead of doing one decision tree, we might do 3,000 decision trees. So every patient goes through these different, and then number of times we vote on it. If it says 5,000 times and it says 3,000 times diabetic, 2,000 times not, then the patient is classified as a diabetic. This is one of them, random forest, which is pretty commonly used. So it's good. So it's not the best there is, but it allows some explainability when I was comparing it to those black box models, which I just put in a value and something comes out. So I hope that's an attempt to show two specific examples of machine learning models in health. So the opportunities for us, despite the concerns I mentioned about big data, we can actually do a lot of pretty good stuff on a regular laptop. We could identify high-risk populations based off of our data. If we throw our gene data in it, that could be part of it. I could predict who will respond or not respond to a surgery, a specific drug, predict events, myocardial infarction, preterm labor, understand the genetic data, and then decide more precise, personalized. Now, the dangers / challenges, data security, that's a big thing for us here. We have a new Data Protection Act in Jamaica. And cyber attacks, we focus on banks and different areas, but in healthcare, they are huge and they are growing. We're not getting ahead of this yet. If you have a system that depends entirely on electronic medical records, this system in Kentucky, the hospital was paralyzed because it's a ransomware attack and they took all data available and demanded something in exchange. How good your output depends on how good your data is. So if your data is not enough for quality, there was some bias, there were problems with how people made decisions in the data, machine learning is not going to fix that. It's just going to apply those biases to its decisions. Responsibility, this is one I think is pretty critical for us. If I, based off of my clinical acumen, think that strategy A is best, but the algorithm says B, what do I do now? If we go with what the machine says, am I liable? But I wanted A. And then if not, who's not? Like the hospital that purchased it, the creator of the algorithm, how do we defend this? And if you're going back to your black box models, if it's not clear, what do we do? I'm coming close to time, so I'm going to mention LLMs, ChatGPT. They're great for getting information quickly. They're not as great for learning. Really learning and being creative means that you have learned some of these specific facts and you can use them and come up with creative ways, which that learning is not as robust if I can get all that information. Why would I try to remember that? I can just find it, type in something on my phone and get it. I'll touch on the idea of replacing doctors, radiologists with these technologies. What do we do? And I'm going to just last touch on the dangers to us in our region. I see this as a potential opportunity for us, but there's also potential for a massive increase in inequality, richer and poorer areas. Problems with technology, the lack of data, the slow wake of development of electronic medical records. This is driven by industry. Smaller areas that don't generate as much income are often not a priority. This is my last slide. What we have to do, this is going ahead. They're not waiting on our permission. It's already happening. We have to make sure we have a seat at the table start with our data. Find ways of collecting it safely and securely. Hospital, private offices, genetic data. Perhaps we need to start developing Caribbean databases, genetic data, clinical data, and integrate how we use data, how we develop machine learning models into basic medical curricula. These are my references. Thank you very much for your time.
All right, thank you very much for a very stimulating talk. As a big ChatGPT fan, I want you to comment on our fear of artificial intelligence. Some people fear the entity or the artificial intelligence becoming sapient or sentient. And also there's a concern about being replaced. Can you comment?
So we're very far away from it being sentient, but we've started that process. But I can't imagine it in my lifetime. It is something worth having distantly in the back of our mind, but we have other problems to deal with, which are going to come up. We're actually already here. Replacing. Sadly, there are some areas or some tasks that, for example, diagnostic radiologists do that are going to be easily replaced. Now, what the algorithm is still, and that's just looking at an image. The advantage the doctor has in the scenario, and a good doctor, is to look at all the other features. The doctor may be able to look at the patient and say, well, incorporate that. You can't put that gestalt, how this patient looks. He looks sick, he looked well, he didn't. I can't quite put that into the image. All the computer has is the image. So it may require us to up our game, but we still will bring something extra as a physician, nurse, some kind of practitioner working with that patient. But there are a lot of tasks, simple, repetitive, look at slides, that are going to be better done on some levels by this technology.
All right, with that, I open up the floor to comments or questions.
Yeah, this is Dr. Bloomfield again. Very interesting talk. The replacement doesn't bother me. What I'm concerned about is inequalities. You know, in other words, there are certain places that will be better served, ideally served, and then there'll be certain areas that will be totally underserved with very little assistance or help to the population in those areas. How do we get over that?
Well, we need to treat it absolutely urgently. So this is, as we stand right now, I think they are moving, the developed world is moving faster than us. So there is, nothing changes, the inequalities are going to get larger. And I think we need to absolutely take control of the process, start collecting our data. That's easier said than done. You can collect large amounts of data and have it securely. And have it in usable forms, that someone can jump in and quickly use. There's a legislative requirement, you know, to govern how we use it, safety, which is not stuff I'm familiar with, but it needs to be part of what we do. There's the possibility, for example, of other people using our data on us. We are not able to use it for our purposes. So there's a lot to do, but I'd say we need to start with our data. There was a question in the type.
Yes, Dr. Maxine Gossell-Williams, you have a question?
Thank you very much. Very interesting presentation, Dr. Toppin. Really enjoyed it. I want to get your advice in terms of corruption, you know, the data, putting in corrupt data and passing it off as clean data. Just today, CNN, for example, had a report about an Uber, a self-driving Uber running the red light because it got corrupted. What's happening to ensure that the data actually goes into the model is actually clean?
Well, we're moving towards automating some of that. But I would say if any project that I start, when I get the data more than half of my time, the initial half is just going to be checking, double checking what makes sense, what doesn't belong. I may send people back, this doesn't make sense. All of these values make no sense. So there's a lot of time in cleaning. There may be a point where you can use AI to automate some of that, but that's still right now, that's the least glamorous and absolutely essential component of the whole process. I just wanted to, there was a question typed in from Danny Davis, and he was asking about what platform. I primarily use R, but I'm switching because of some better stuff. I think R is much better for data cleaning and processing and visualization, but Python actually has much better ways to set up and test all the different machine learning models. So I'm trying to switch. I'm trying to decide if I should just use the two of them. I'm very comfortable with R for the initial part of the process, or just switch to Python and then use Python for the machine learning, or just switch to Python.
We have a question from Dr. Franson.
Thank you very much for a marvelous presentation.
Thanks.
I'd like to get your perspective, Dr. Toppin, on where we are now with the embracing or getting or being able to incorporate quantum computing into all that we do now with what you have just presented today. What is your projection? Are we near there, or is that going to be a while before quantum computing can come and enrich all of this?
Well, it depends on your we. There are places where it is already going to be, because of the size and the rate at which the data changes, that's going to add a lot of value. It's not going to add any value for us in the region, and maybe regions like us for now, because we're not, approaching the point where our data sets are so huge and so they're varied. They include some pathology images and some recordings. We're not there. So the advances of quantum computing are not going to help us anytime soon. It will help some people.
But won't we be able to collaborate with some of those other places to, just like how we refer patients to this place or that place in Florida or wherever, won't we be able to do some collaborative work in that regard?
You can, and I would definitely encourage that. But if I were to look at data sets and say, what proportion do people in my region take up, just based off of relative to their population size to the data sets that are driving a lot of the algorithms, I would say we are way woefully behind. And it really is for us to step up and start participating in that process more. I'll give you one example. There was a look recently at, and I was peripherally involved. It was a study looking at genes associated with breast cancer, and it included some data from the Bahamas and Jamaica. And what kept coming up was, there are these genes that cause associated with cancer in European and American populations, but we kept seeing variant of uncertain significance for our population. What meant there just wasn't enough data. I mean, we're unable, this is a genetic variant that we're unable to say based off of what we have, is it associated with malignancy or not? Because our data on that was lacking. I mentioned it is driven by industry, and people are looking at companies are making the most money. And the money that comes out of the Caribbean is minuscule compared to if I can capture the North American market, European market. So if you just look at where the money is, we're going to get left behind. And there are people that will collaborate, but we're talking the scale we're talking about is very big.
Thank you so much. This is almost flashback for me. I remember one of the first courses in medical school in the early 1970s. The big hot topic was the electron microscope. And look how far we have come now. Thank you so much.
You're welcome. Yes.
All right, thank you, Dr. Toppin. We'll move on to our next presenter, Dr. Lockhart. He's a registrar here at Princess Margaret Hospital. He's going to give us a talk on bacteremia in hemodialysis patients.
Hi, yes, good day. Just connecting my screen. All right, good day, everybody. My name is Dr. Lockhart. I am a member of the internal medicine team here at Princess Margaret Hospital. It is a pleasure for me to present to you the topic of my research topic for my DM examinations. It was a retrospective evaluation of bacteremia in the end-stage renal disease population on hemodialysis at Princess Margaret Hospital. And this was between January 1st, 2022 and September 30th, 2024.
Sorry, Dr. Lockhart, could you change to presenter view if you can?
Oh, sorry. 1 second, please. You know what I will do? I just remove it here. Is that better? It is not. One moment.
Yeah, just press slideshow now. Top left corner from current slide. Just press that button. Correct. Perfect.
All right. As we know, managing bacteremia in the dialysis population is a very challenging task. And this is due to a number of infectious risk factors that occurs within this population. Now, for global research, it is actually risk mitigation. Sorry, I am not saying, there we go. Yes. Global research on risk mitigation has improved, informed by clinical guidelines to improve our patient outcomes. And this is mainly as per the IDSA guidelines. But the duty lies on individual countries essentially to execute local research to ensure that essentially your population is included when these guidelines are being produced. My goal was to add to the research. And by doing such, I had a retrospective review of the medical records at Princess Margaret Hospital, specifically those from the dialysis unit, as well as those that are available to us via electronic medical record through our ICE system. And the time period was already discussed, as well as the site. The data, which was analyzed, was initially captured using REDCap and ported into Stata, where I was able to produce descriptive, comparative, as well as logistic regression statistics for our data to determine essentially what our population characteristics were, as well as what was the underlying causative agents that is driving our infectious incidents. For my study, there were 371 patients that were evaluated over the course of this time period, 97.6, so pretty much 98% of which were Bahamian. The gender disparity was 56.6% male, 43.4% female. Of those, of the population, the most significant CNCD was hypertension, and this included both primary as well as persons who develop hypertension secondary due to their renal disease, as high as 94%, as well as diabetes mellitus with 40%. And our all-cause mortality over the time period was 22.6% for our population. And this is, here we can see a table showing the exact breakdown of our values here in the Bahamas. Additionally, we have on this table, you can note at the bottom that we were able to see as well that our average age of initiation for all patients were approximately about 51, plus or minus the standard deviation. For those at the end of the study, would have been based on if they had were still living or they were deceased, which would be 54.29 if they were living, but those who were 59.5 plus or minus the standard deviation if they had passed, giving an indication that those persons who are older would obviously had a more complex and clinical course as well as a poorer prognosis. Here we see our table of comorbidities, identifying, again, diabetes mellitus having 39.6%, hypertension 94.3%, and other disease pathologies such as obstructive uropathy, systemic lupus erythematosus, HIV, malignancy, going down the line as we have a reduced frequency of these instances. I would say that particularly to the Bahamas, due to the fact that we have a relatively low biopsy percentage for our patients, certain conditions such as glomerulonephritis actually may be a bit underrepresented within my data set. Our vascular access types, it was noted that approximately 66.58% of our patients were using or had a catheter, central venous catheter in situ, whereas only 33.42% had some degree of arteriovenous access, let it be AV fistulas or AV grafts. Now, the meat of the matter, given the fact that the study was looking at bacteremia, it found that of the 371 patients, 159% of those, or about 42.9%, developed a bacteremia, and 30.8% of those bacteremias had some degree of antibiotic resistance. Now, of the 159 patients, another 73 patients, or 45.9%, went on to develop a second recurrence of bacteremia within the study period. And those persons had a higher rate of antibiotic resistance of 38.4%. Now, the most prevalent organisms were the Staphylococcus species, as you can see here on the next slide. The Staph epidermis would be noted to be the most prevalent, followed closely by Staphylococcus aureus, whereas Staphylococcus aureus, as you can see here, was the only organism that had a significance of resistance, indicating that the primary resistance for the population actually came from likely multi-drug resistant Staph aureus, or MRSA, methicillin resistant Staph aureus. And this is for the recurrence, showing, again, Staphylococcus epidermis being the most prevalent amongst those isolates. Finally, the statistical analysis rounded off with a logistic regression model, which showed or identified significant risk factors for the development of bacteremia within the population. And of those values, it found that the use of central venous catheters had a odds ratio of 5.3, which represents a 530% increased risk of developing bacteremia for those patients who had a catheter, central venous catheter in situ. And there is a number of patients, because it was a retroactive study, there were a no documented access type, which showed an odds ratio of 4.3 or 430% increased risk. And interesting enough, the outsourcing of the patients to our satellite site A had a reduction in their odds ratio, or a positive prognostic indicator, with an odds ratio of 0.47. And this is the regression model of, as you can see at the top, central venous catheters, followed by unknown access. And all the way here at the bottom, we have the presence of the use of satellite site A, which had a reduced odds ratio. So discussion for this essentially shows that this is the first study that I was able to actually, that was done in the Bahamas on our dialysis population, showing pretty much a comprehensive overview of the baseline characteristics and comorbidities of this population set at PMH. The study went on to determine the incidence of bacteremia, as well as the causative agents and their resistance patterns. And it went on again a little further to pretty much identify the risk factors for developing bacteremia within the population. So here we find the study essentially underscores the need for targeted interventions to optimize vascular access practices and a robust antimicrobial stewardship program to reduce infectious burdens and improve clinical outcomes of our patients. Thank you for your time. This is the references used for my literature review and my research, and a few acknowledgements for the persons that helped me along the way. All right, thank you. Any questions?
All right, thank you, Dr. Lockhart. So I'll start by asking you a brief question. How does our data compare to international data? And for quality improvement and patient care, what are our goals?
That's an excellent question. Essentially, based on what the literature review showed for our data, is that our numbers are significantly higher. However, well, I'll take the word significant out of it. Our numbers are higher, however, the percentage does not raise to a statistical significance. And saying like that makes note that to evaluate for significance, we have to develop a p-value, but our p-value was greater than 0.05. So even though our percentages were a bit higher, we were not statistically significantly higher. Now, in terms of what that means for just to get the second part of the question, repeat the last part, please.
What are our goals? Are we trying to decrease the infection rate to a certain level? What are we going to use this data to do?
So the use of the data. The use of the data is very much to do exactly that. Our goal is to reduce the risk of infection and hopefully reduce the incidence thereafter. So as identified by the research, the primary identifiable source for the in terms of risk factors was actually the use of the central venous catheters, the use of our Shiley catheters as well as our perm caths to dialyze patients almost on a permanent type basis. By doing this, we increase our patients' risk factors by about 530% in terms of developing bacteremia. And as we know that by increasing our risk factors for developing bacteremia, we also increase our patients' risk factors for having a poor prognosis and increasing their risk of morbidity and mortality. So our goal going forward was hopefully to use this data to hopefully come up with systems where we can have access placements through our institution in a shorter time period, as opposed to patients waiting months to years to get a arterial venous access. Hopefully we can aim for weeks. And by changing over from the catheter-based systems to a arterial venous system, we can reduce our risk factors across the board. Now we actually have the evidence through the data we came up with my research to show why we should aim for these targets, these shorter time to get access to patients.
Excellent. Hi, Dr. Morris here. Excellent presentation. I am shocked by your data, but not so in sense that, you know, the highest risk was related to central venous catheters. And I love your last comment that you just replied to the moderator. Essentially, we need to get our access early. And I hope Dr. Lucas is still on board because we need to engage him pretty early along with Dr. Ferguson. Certainly, I think, yes, I agree. I think when somebody gets a central venous line in, they probably should be getting an AV fistula at the same time. And then as soon as their fistula matures, take that central line out.
Most definitely, that is actually the gold standard recommendations for initiating somebody on hemodialysis. The majority of patients, notably, will be initiated using a central venous catheter. Let it be a temporary or what we call the perm cath. However, the global recommendation is actually to have 90 to 95% of all patients on dialysis chronically to be dialyzed via arteriovenous accesses. About the additional maybe 5% of persons would be via grafts specifically, and less than 1% would be dialyzed using some type of permanent catheter-based system. So within our population, we are definitely not meeting the global standard due to our heavy use of catheters for dialysis.
Can I make a suggestion? Why don't we do a quality improvement project that's measurable? And I'll be happy to be a part of that quality improvement project because one of my things, quality improvement and patient safety.
I am on board with that. Thank you.
All right, thank you so much.
I saw a comment in the chat. I can't see it. Okay, acutely dialyzed patients get a non-tunnel cath followed by fistula graft. That's by Dr. Judith Hall. I see Dr. Frankson has a hand up.
Yes, sir. I just wanted to know if, and it's so nice to see you, Dr. Lockhart, and all of you. But I just wanted to know, did your logistic regression show any statistically significant difference by any of the demographic features or comorbidities?
Actually, after evaluating for all of the CMCDs and demographic features, everything, there was no statistical difference between any of them. The only significance came from the use of the catheters, as well as the persons who were dialyzed at satellite site A. However, I would say this, it is a bit of a skew, and that's because the practice here at Princess Margaret Hospital is to only outsource patients who essentially have a better prognostic outcome, meaning that those patients who would have chronic dialysis access issues because their vascular paths would rarely be outsourced to outside institutes or satellite sites for dialysis. So only those patients who are very stable, who likely have arteriovenous fistulas or grafts, who have well-controlled disease would be outsourced. So due to that, the prognosis of those patients who would have been sent out from our primary institute would be here at PMH, they would definitely have a better prognosis, everybody who were outsourced. So it's a bit of a skew, but that's something that is more fleshed out in within the full research document. And it's also something we would note working within the institute.
Thank you.
All right, thank you, Dr. Lockhart.
All right, thank you.
penultimate speaker is Dr. Hannah Thompson. She is currently a senior house officer in the Department of Surgery here at the Princess Margaret Hospital, and she's going to be discussing IVC filter placement and retrieval here at the hospital.
Good evening, everyone. I'm Anna Thompson, and I will be presenting our study on IVC filter placement and retrieval at the Princess Margaret Hospital. And I have no disclosures. So venous thromboembolism is the most common preventable cause of death in hospitalized patients. An inferior vena cava or IVC filters are devices designed to prevent pulmonary embolism and reduce venous thromboembolism related morbidity and mortality. Over recent years, there have been many debates about their efficacy, safety, and appropriate usage, and these have influenced clinical practice. So a bit of history about IVC filters. The device was first introduced by Greenfield as a permanent device in 1973. And the recommendation for retrieval of IVC filters after they're no longer medically necessary prompted the creation of the retrievable IVC filter. Now, there are many indications for placement of an IVC filter, notably contraindication to anticoagulant, complications of anticoagulation or failure of anticoagulation, whether or not the venous thromboembolism has iliocaval involvement, or sometimes in cases where the patient doesn't presently have a venous thromboembolism, but might develop one in the near future. So although these devices can be very useful, they are not without their complications. So short-term complications include inability to cannulate the vein for placement of the filter, arterial puncture, hematoma, hemorrhage, introducing an air embolus, pneumo or hemothorax, infection or thrombosis at the site of access, misplacing the filter, or even perforating the inferior vena cava. Longer term, these filters can migrate, tilt. The struts that they are secured with can fracture, and those struts can actually also perforate the IVC. They can cause IVC thrombosis and lower limb swelling or even recurrent DVT. So since the advent of retrievable filters, which were approved by the FDA between 2003 and 2000, it was thought that they were zealously placed to the point where the FDA decided to issue a warning against the usage of inferior vena cava filters in patients that did not necessarily need it. They were having a lot of complications that probably outweighed the benefits of the filter being in. So rates of IVC filter retrieval are only about 12 to 18% in resource-rich USA, despite the risks of these long-term complications, and despite retrieval after the filters are no longer necessary is encouraged. And just a reminder that retrieval of these filters are also not without complications. So there have been a set of guidelines postulated by the Interventional Radiology Society to place and retrieval of IVC filters include, again, pneumothorax or thrombosis of the vein, fracture of the legs with embolization of the legs of the IVC filter, extravasation of contrast, and fistulization between the renal artery and IVC. Thrombosis of the IVC is also one, as well as injury and perforation or dissection of the IVC. So studies have shown that dedicated follow-up programs aimed at retrieving these IVC filters once they're no longer necessary have improved rates and decreased complications in these patients. So we thought, why us? Well, there's no region-specific data documenting our use of IVC filters in a primarily Afro-Caribbean population. And low retrieval rates here may be exacerbated due to our resource constraints. So our aim was to identify gaps in practice and guide guideline adherence to inform strategies that will improve clinical outcomes, optimize resource utilization, and assist in creation of a formal IVC filter retrieval program. We did a retrospective chart review of medical records looking at these patients' demographics, their diagnoses, indication for filter placement, whether or not they already had a confirmed venous thromboembolism before placement of a filter, whether those filters were retrieved, and whether or not the patient survived. And we looked specifically at filters placed between the years of 2020 and 2024 of all the vascular services at Princess Margaret Hospital. So we came up with only 16 patients from our chart review, 9 females and 7 males, ranging from ages 19 to 88. And we suspect that this was a sample that was underrepresentative of the true population, as all of the IVC filter placements are coded under the title of insertion of a totally implantable vascular device, which includes any vascular device of graft, a central venous catheter, or a hemodialysis catheter. And also the fact that most of the IVC filters placed are on a consult basis versus patients admitted under the vascular services, and they're not necessarily documented in our surgical diaries. So this emphasized the need for our registry in the future. We also did a telephone survey follow-up previously used by Orshida et al. In a study they did in 2019, of which we had a 70% response rate. So from our data, 14 of 16 patients had therapeutic placement or already had a pre-existing venous thromboembolism before having an IVC filter placed. And 12 of them had them placed via the right internal jugular vein, followed by the left internal jugular vein and the right subclavian vein. Our rate of IVC filter retrieval was documented at 0%. None of the 16 patients had them retrieved. And 10 of 16 of those patients remained alive at the time of the study. So the results from the survey showed that all 7 of the patients who responded were aware of them having an IVC filter placed, but only 3 of them knew that IVC filters are potentially retrievable or removable. These patients claim that most of them, 6 out of 7, claim that they were unaware of the risks and benefits of having an IVC filter placed and having a dwelling IVC filter. About 4 of the patients who responded to the survey were followed up by any physician, mostly with the vascular service. So these results just emphasize the importance of patients' education and awareness, with a greater emphasis on informed consent being needed. As soon as before we are able to do this procedure, we have patients sign a form claiming that they are aware of all these risks and benefits, which is just something for us to think about. We think that insufficient operating time and space may largely contribute to the lack of emphasis on retrieval of these IVC filters, but also 7 of our patients might not have been considered eligible for retrieval due to ongoing risk of venous thromboembolism, including patients with known malignancy. And many of those patients had already expired by the time of the study. So our limitations include that it was a single center study, and our public script filing of our patients' medical records which lead to us having an incomprehensive registry and a small sample size. Further research may look at how implementation of this dedicated IVC filter retrieval follow-up clinic can affect our retrieval rates, and also look at the presence of complications of IVC filter placement and retrieval in our population. And that is the end of this presentation. Thank you very much. And here are my references.
All right, thank you, Dr. Thompson. Very insightful. I will now open the floor to comments or questions.
Thank you.
there are none, we'll move on to our last presentation for the session. Our next presenter is Professor Gossel Williams. She's Professor of Pharmacology and Pharmacovigilance at Mona, Jamaica, and she will speak to us today about mentorship in research.
Hey, good afternoon, everyone. Are you seeing my slides, Dr. Tinubu?
Yes, I am. Just need to put it on presenter. Yes, perfect.
And is it moving?
It is.
Okay, great. Yes, so good afternoon, all. Thank the organizers for inviting me to participate in your annual research activities. I'm going to just disclose from the beginning that I have no professional training in mentorship. I suspect Alfonso invited me because I've been at university too long, right, Alfonso? I've probably been supervising students for over 30 years. So what I'm giving you is really just best practices as it relates to my mentorship of students, both graduate and undergrad students in research. So today what I want to look at is, reasons why you should mentor, some of the supervisory models that I'm aware of, and looking at, what will work for you or not work for you. The importance of setting terms of engagement between you and your mentee, and the support that the university has for you as a mentor. So I thought I'd start here. This is one of the many guidebooks that the university offers. It's available on the Graduate Studies website, and it speaks mainly to the university's agenda as it relates to research informing your teaching. So it starts off by saying scholarship, research, creativity, and their application to human development are foundations of university life. And I'll just move to the section that I've highlighted in the rectangle, red rectangle here at the bottom. Research informs the teaching programs and is applied to human problems and the advancement of society regionally and globally. And this is probably something that you haven't thought about at all in all the years that you've been at university in terms of engaging your research or in using your research to inform your teaching. And it's something that I want you to keep in the forefront of your thoughts as we go through the presentation. If you haven't thought about it, it's something that you want to think about, especially if you've been in the university system as long as I have been. You certainly don't want to be just teaching every year, rolling over the same content without actually engaging it with your research. So why mentor students? And on this slide, I have 10 reasons. I won't go through all of them, they're listed there. First one is expectation to help others to achieve scholarly development. Our Lord Jesus says, the more we give, the more we will receive. So that is kind of follows in terms of your life here on earth. Facilitate development of future research leaders. Advance cutting-edge research by supporting early career researchers. Increase your research visibility in your field. I mean, if your work is important, certainly you would want it to continue once you decided to part ways with it in terms of, going into retirement. And so you really want to ensure that it continues if it is important. I want to just talk a little bit about the last bullet that I have at the bottom. I think for me, that was actually the most important, has been the most important point. Supporting your publication output in the presence of other demands of your employment. When I started my teaching journey at university, it was around 1995, I think, 94, 95. I had started my family. I got married in 95 actually. And by 2002, 7 years down the line, I was completing my PhD defense and almost having my second child. And the whole 7 years that I was a PhD student, I was in charge of over 120 medical students in pharmacology. So I had to manage all their labs. A number of MPhil PhD students were also put under my guidance. And of course, as an assistant lecturer, that's where I started, I had to be publishing. So how do I actually balance all of that? So it's important for you to recognize that your promotion does not depend alone on your teaching. The ordinances, Ordinance 8 is a specific one that we're looking at. It emphasizes how promotion works in the university. Item 14A, the appropriate appointments committee shall not renew the contract of a member of staff completing the first 3 years of service unless that member of staff has shown evidence of diligence, competence, and integrity. In considering to renew an appointment under this clause, the appropriate appointments committee shall, in respect of the academic staff, senior administrative staff, and professional staff, take into account performance in the following areas of activity. And I've highlighted these areas on the right-hand side: research, publication, other scholarly activity, teaching, contribution to university life, public service. And I'd like to tell the audience that not even the registrar, campus registrar, Dr. Stanbury, gets away from all of these activities. All of these factor in terms of promotion. So how are you going to get all of this done? For the DMs and the clinicians, and I mean, one of the reasons I suspect Alphonse asked me is that I don't only work at the basic science realm in terms of pharmacology, but I do interact quite a bit with a number of the clinicians. And as Deputy Dean for Graduate Studies and Research, 2 years running, I did function in that capacity in organizing, well, understanding the relationship between you and your DM students. So I realized not only the DM students, but you as mentors have to manage your hours at the hospital in terms of service, plus mentor students, plus examination activity, and of course, family life, etc. How are you going to do all of that and actually advance in university? So these are all important in terms of your advancement in university. And so we have to develop some kind of system to allow us to manage all of this. And so the mentorship system that we have with our students is going to be important. So what I'm highlighting on this slide is three different models that are available in terms of mentoring students in research. Model A reflects a supervisor's research agenda, of which they're sharing part of it with a research student. So to explain such a model, you probably as a researcher, as a supervisor, maybe your interest is medicinal cannabis, for example. And your student has come in and their interest is not so much the medicinal aspect, but perhaps looking at the different types of plant extracts. And maybe they're looking at, which plants to be used for epilepsy versus which plants to be used for analgesia. And they're probably taking it from another side rather than from a clinical side. And I'm thinking that maybe this model, an example of this model is, let's say you decided that you wanted to pair with a basic scientist who is involved in genotyping plants. So you'd probably operate here more as a co-supervisor in terms of facilitating any clinical assessment of whatever plant they're working on. So there is some relationship between you and the student's work, but it's not your primary area of interest. It's Model A. Can be time consuming, but it really is just a matter of relationship that you're going to have with the student and possibly the co-supervisor who's really driving the research. Model B is taking your DM student or your PhD student or your MPhil student totally into your agenda. So whatever the student wants to do, it has to fit in your agenda. And so that way you're really just interested in working through what your focused area is. This can become very important, especially if you're going for professorship, senior lecturer. At that point, they're now looking at focused research. You really don't want to see somebody who's just, bopping here and there. So you may want to consider this option because it's probably the tightest option in terms of your time. Yes, it may not engage your student initially in any kind of serious independent thought, but perhaps this would work for a DM student, and the independent thought can then extend if that student wants to now consider a PhD. So this is this is a model B. Model C now is one that I see a number of the DM supervisors engaging. And I think this is a major challenge to you all with all the hours that you have in terms of hospital service. How do you engage a student in independent work? No relationship with yours. It's going to take up a lot of your time. And whether this is really a suitable model, I really would not say that it is, but these are the models that are available. I don't know if I see Dr. Frankson. I think I saw you on the line. So please, if you want to open your mic and engage. I really don't like the Zoom model and with all of us being, well, my audience being silent, and I do recognize that I am the block between going home and remaining focused. All right, so your role in creating a supportive community for your mentee. One of the first things you want to do is actually in your introductory meetings, advise your mentee about your area of expertise. Perhaps you want to send them to do a little research to find out what kind of work you're involved in, but it's one of the conversations that you want to have. Make it very clear what your areas of interest are. You want to maybe give them a little idea of your supervisory experience. What are your expectations from the relationship, the work that you're going to be doing with the student, and some idea of your professional network are part of the conversation that you should have. Of course, what you're doing as a mentee, you're creating a relationship that is supposed to support that researcher's that development. And so you really want to ensure that you have a good rapport with that student. Are there you should display some interest in their ideas. And of course, you want to give them some guidance as it relates to the university support, regulations that guide the process. And I'll stop here to kind of give you a little story about how I got into regulations of the university. When I started my MPhil journey, I had 2 students, and that tend to do very well in terms of time management. So both students got their projects completed on time. One student completed her write-up and was able to graduate within the time period. But I had another student, the other student had completed her data collection, completed her data analysis. All that was left was for her to write up. She insisted that she needed to go out and work. Our MPhil students tend to get full support financially in terms of having departmental support, which covers the tuition and then the demonstrating labs. But it wasn't adequate for her, and she wanted to go out to work, which I supported, and so she went off. So after some time, she never made any contact with me, and so I decided to write to grad studies and ask them to remove her from my my sleuth of students, because I mean she was really holding up a space. And at the time, I believe Professor Jackson was the director that wrote me, and she said that, you know, the regulations do not facilitate that act occurring at this time. Not enough time had passed, and I was therefore compelled to call the student in and to work out a timeline to get that project finished. So at that point, I recognized how important the regulations were, not only to protect me, but to protect the student. I mean, the student is the one that university really wants to ensure gets the best for the money they pay or whatever time they put in. So that is a little segue I'm just giving you in terms of how I got interested in understanding university regulations. And it's something that you should really engage your students with. You'll be surprised at the number of students that will come through and not recognize the whole chain of command in terms of the fact that you, the supervisor, is their first contact, who they would go to in terms of registration, why they need to register each semester, etc., etc. So you are going to be the custodian for that. You will want to support your students' development, so you need to encourage them to, you know, to take on student-led ideas, maybe to lead your journal club or your seminar meetings. collaborations, meeting with other journal clubs. There are quite a number of journal clubs in the university. And I wanted to recognize Bahamas is part of MONA. So you should try to engage with all of the other journal clubs that take place through the MONA domain. Most of them are actually now engaging with the Zoom platform. CARES is one of the healthiest set of journal clubs that I've visited. I found them to be very good in terms of mentoring the DM students, opportunity for you to learn quite a bit about research and a network that can support you. So I would suggest that you even try to engage with them. Academic growth outside your influence, and encourage them through that pathway. Participating in conferences, those are things that you really should encourage. Having them join societies, make them part of your professional network, pairing them with your senior DM students. I was on for the conference for about maybe 2 or 3 hours, and the papers that I've seen, they're quite interesting in terms of research. I recognize that for the most part, they are projects that can continue, and I've found that a number of the DM projects are actually put on the shelf and not continued to completion. And so I would recommend that as mentees, you have a project that is going that is of interest to you. The DM student has completed it to a point A. It needs to be continued to complete it for publication. That you really should consider a process where you can pair a senior student with your new DM student so you can have some progression of that work. Right. Now, one of the first things that your DM student will need to do is to write a project proposal. And I'm not going to go through these. These are the basic elements that you will all know and be aware of. So I will share the slides with the team so they will be able to share it with you all. But don't assume that because you've given them a template that they're going to know where to start. And I suggest that you also give them some samples. You would have had some of your past students work. Give them some starting product for them to be able to model for their research project. Of all the graduate programs in the university, the DM programs are the only ones that don't have a structured research course, which is a real unfortunate situation. As Deputy Dean and following behind Marvin Reed, we have tried many different models. We've tried to encourage the students to actually register for structured courses. We've actually waived some of the fees, or we've gotten course coordinators to waive some of the fees so that they would register and audit and get the courses done. But that just has not worked. Students don't do anything unless they are compelled to do it. So for the past 3 years, what we've done as the unit, the clinical and translational unit of MONA, we have created a whole platform of resources for DM students. And I'm going to ask you to ensure that your DM students engage with that content. It's important for them to have some structured research course. So you want to set some terms of engagement, some deliverables. As I mentioned, students do not engage in anything unless they are compelled to do it. So set some timelines. When do you want the project planning design to end? When do you want the data collection to end? When do you want data analysis to end? When do you want the write-up to end? Use these timelines as your marker of a student progressing successfully or satisfactorily compared to not progressing. These manuals help you in terms of setting these terms of engagement. They are all available on the Graduate Studies website. Please engage with them. I really don't want to go through them, but please download them. This one in the middle, Manual of Procedure, very good on setting the timelines, making the students understand why they need to register, what happens if they don't register. When they don't register for a semester, it can result in them having to pay for readmission, requesting waiver of particular regulations. Be familiar with this as supervisors with all of these booklets. They will help you to help the student in terms of meeting the deliverables. As a faculty, we provide lots of support for our supervisors. I think you should all be familiar with this book. It's available on the VLE platform. It's available on Faculty of Medical Sciences webpage. This book provides you the whole with information to complete a research project from conception right down to paper production if you decide to publish. And I'd like to acknowledge Dr. Jacinth Mullins for the production of this practical guide. Along with that, for the past year, we have worked on creating video modules of particular aspects. Right now on YouTube, and the link is provided here, there are 8 modules that cover different aspects of the research journey. I'm going to ask you to consider and figuring how to integrate these modules or viewing of these modules in your assessment of the students. DM students, I believe, go through assessment every 3 months. There's a form that you have to complete with the student. Perhaps consider adding aspects of these modules into those assessment so you can have it ticked off as student completed. They're very useful. All the persons who have engaged with them have indicated how important or how significant they have been to their research project development. We also, the Clinical Translational Unit, also started an engagement with research liaison officers. And so each department has a liaison officer that we meet with, generally once per month. And Alfonso is the research liaison officer for you. These research liaison officers have been trained in the basic research activities, as well as where to go if they need additional help. Alfonso, for example, has been trained in how to register clinical trials, right, Alfonso? And so when you need to register your clinical trial, and you must register your clinical trials on clinicaltrials.gov, he should be able to facilitate you with that process. We have done workshops with them, workshops on journal manuscript writing, biostats, technical guidance to support conversion of your thesis to papers. All of these workshops are available on the YouTube channel for your viewing as needed. In terms of the university, along with the handbook, there is quite a bit to support graduate studies research. Most of the funding opportunities really are for our MPhil and PhD students. Unfortunately, there's no funding for DM students as it relates to that. But yes, that is offered at the graduate level. Also recognize that the Office of Graduate Studies and Research does provide oversight to monitor the students. All DM supervisors are required to report by January 30 for semester 1 and by June 30 for semester 2. You're required to complete the supervisor's report, which details the student's progress. So you will see, for example, you have to indicate how many times you've met with the student. You also have to indicate whether you're satisfied with the student's progress. That can only happen if you set some goals. Those goals not being met will help you to determine whether the student has satisfied and can move on. You're also required to put any other comments. The university does recognize that life happens. So if it so happens that a student was in some stressful situation, those things are taken into consideration. But it is important to you as a supervisor to make sure that you document all irregularities or all successes of the student so that both of you are protected should a problem occur. And of course, I'm not sure if you're aware, they're now even giving supervisors some financial gains if they complete their students' progression in a timely form. And I can have that information sent to you at a later date. So with that, I'm almost at a stage where you can now sign off and go into your sojourn of having some wine and cheese. I'm suspecting that the organizers have some kind of refreshment after keeping you here all day. So I'll leave you with a little story which is from the book Research Supervision for Supervisors and Their Students. And this book can be accessed on Amazon. So it's a story about a rabbit who was writing a thesis document, the title of which is The Superiority of Rabbits Over Foxes and Wolves. So he was in his little vegetable garden, and while he was there picking his carrots, a fox came upon him. And the fox, of course, you can see would want to eat him. And the rabbit looks at him and says, no, 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 please don't eat me, don't eat me. We have a wolf that now has come upon him. And of course, the wolf does find him tasty and he says, no, 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 please don't eat me. I'm finishing my PhD. It's on the superiority of rabbits over foxes and wolves. And of course, again, the wolf would think that he's crazy. That can't be. And rabbit convinces him to follow me into my little office. Let me show you. So he goes into the office with him. That was the last we saw of the wolf. And so our little fella he's able to live for another day. So he's now at the end, and he's there in his garden collecting his carrots, and another little friendly rabbit comes up and asks him, why are you so happy? You look, so overjoyed. And he says, I've finished my thesis, the title of which is The Superiority of Rabbits Over Foxes and Wolves. And his friend looks at him, huh? That can't be. And he says, well, if you don't believe me, follow me. Let me show you. So here he is going into his little office, his workspace, to show his friend where he works. So when his friend looks in, he sees a little computer desk with all the notes. This is where he was doing his PhD work. And he looks along and he sees 2 stacks of bones. And in the middle, you can see Mr. Lion right here. So I will leave you with the storyline and ask you what matters. I will tell you that in the story, they actually, for them, their moral of the story is that it's not the student that matters, it's who is the supervisor. But I'll leave it at what matters, and perhaps if you're not too much in a hurry to leave, maybe you want to engage me in what you think what your perspective is. And with that, I thank you all for staying with me, and maybe we can talk if you wish. Thank you.
All right, thank you so much, Professor Gossell Williams.
Mhm.
With that, I'll open up the floor to any comments or questions. Dr. Franson?
I was tempted, so I'm yielding to the temptation.
All right.
And I'm well known for opposing research in the DM, because I think that the DM should be structured for what the persons are going to do after they get that degree. And I hope my specialists will not be doing research on me, but will be using research very intelligently. So having said that, one of the contexts in which I say that is not to exclude research from people who are doing their DM, because the university does provide for people to do conjointly a DM and PhD. And I think that with the limited resources that are available, we should really get the kind of research where we're going to hope to see publications and so forth, and subject matters being dealt on that are of national and regional consequence. We should be inviting people to do a conjoint DM PhD, and really let the DM folks be masterful in the area of their specialty, and the PhD folks, and if there's a conjoint DM PhD, let them be the ones who are steered towards getting the kinds of expectations and the kinds of time investment and quality of data collection and so forth investment that you can have those. Because I think it's a really serious ethical breach when you consent somebody promising them that when they participate, their data will be used to advance something in the region, and you never deliver on it. I think it's a breach of ethics of one of the highest orders, and that we have actually been training our DM residents to actually not fulfill that very much, that contract that they made with their participants in their studies. For me, that's a serious matter. And I know I'm not the one presenting, so I will shut up at this point, but I know there are many solutions to that. And I have certainly gone on my podium and preached on that and got in trouble with that and all sorts of things with that. But I think we need to be realistic. Just one last thing, surgery has showed us the way. Surgery has really focused their students to be masterful in their craft and been highly selective and so on and so forth. I don't think we have to be as restrictive and as selective as surgery for most of our DMs, but there's something to learn from the way they have approached it. Surgery does have a lot to learn, however, because they need to have scholarly level research, their casebook kind of research and publications. They actually have, in my opinion, an easy and unfairly easier pathway towards academic advancement, because their case studies is mostly what they present, and they get right through to professorship easily on that. I think the field is still ripe for much improvement. I rest my case, but you caused me to talk, so I talked.
Well, I mean, Dr. Frankson, I mean, they're opposing views. The truth is that the best researchers that I've had are the ones that I mentored from undergrad. And so I think you really have to kind of sensitize them right through their journey. I do agree. I think some of the DM projects are really overextended. And I in some regards, they're asking students to do projects that they don't even have funding for. And really, it's just a matter of, whetting the students' appetite, sensitizing them. And I think there needs to be some kind of restriction on what they should do. But I won't extend the conversation. I think we can say pros and cons of both sides.
Thank you very much.
Nobody else? Well, maybe I should actually visit Bahamas and sit with you all. Maybe then I'll get some probing discussion as the one with Frankson.
You're more than welcome.
I'm with you. I'm with you now in Jamaica for the last 3 years. I'm in Mandeville, so maybe I should pop by and come see you in Mona.
Yes, you should. I should tell you that I'm actually acting director for graduate studies for the next 6 months. Professor Roy took some leave, so I'm sitting in that office for a couple months.
Wonderful. God be with you.
It means that I've been here too long, Frankson, doing graduate studies work.
Good then.
So with that, we conclude our session 4. And let me remind everyone that you can claim 2.5 CME credits. The QR code will be shared. Session 5 begins at 1 p.m. tomorrow, and you can sign on to the link. Thank you and good night.
Good night, everyone.
Good night.
Good night.
Thank
Good
you.
night.
Excellent.
Good night.
Excellent.